So I'll be talking about the measurement of liver fat with MRI. Fatty liver, as most of you who are interested here are interested in fatty liver, I suppose, is defined as abnormal and excessive, that is more than 5% of the hepatocytes with lipid vacuoles within the hepatocytes, primarily as triglycerides. And there are many causes, and the most common cause, as we all know, is non-alcoholic fatty liver disease. It can be a part of hepatitis, drug-induced alcohol, as well as parental nutrition and pregnancy. Now, as Dr. Dilavri just mentioned, non-alcoholic fatty liver disease is probably going to be the most common chronic liver disease in all over the world. It is definitely the most common chronic liver disease in USA and Europe. And it is also associated with diabetes and as well as a risk factor for diabetes. It is associated with increased cardiovascular mortality, and nearly about 4 to 5%, and probably that number is going to be higher, develop cirrhosis and into end-stage liver failure. But the good news is that fatty change in the liver is reversible, especially in the early stages. And non-alcoholic fatty liver disease has a spectrum of simple steatosis, in which there is just fatty change, and it is just the risk factors are similar to a general population who does not have a fatty liver. And there is very minimal risk for progression into liver fibrosis. And and the second part is the non-alcoholic steatohepatitis, which can have inflammation with or without fibrosis, and both of these have risk of progression to fibrosis and cirrhosis, and these are the ones which are having increased risk with cardiovascular morbidity as well as metabolic disease. So the question really comes up is, why do we need to measure the liver fat? Is it for prognostication? Is it for severity? Actually, I do not know the answer because it's still an open question. Why do we need to measure the fat? But especially in two particular indications, I do know why we need to measure the fat is to know the functional reserve of the liver, because fatty liver is known to have lesser functions or less than the normal liver parenchyma. This is specifically directed to liver donors who can be good donors if they have less fat in the liver or to a particular cutoff, and as well as patients who are undergoing hepatectomy, especially if there's a large chunk of liver is to be excised, and if the patient has fatty change in the liver, the functional reserve is going to be less. So these are the conditions where you definitely need to know the amount of fat in the liver. It can also be used as a biomarker for assessment of response to interventions by the clinicians in the form of lifestyle changes, either the diet, drugs, or any other non-interventions to reduce body fat. So histologically speaking, the grading of the hepatic steatosis is less than 5% of the hepatocytes having fatty vacuoles is considered normal, and it is graded into three types: mild steatosis, moderate steatosis, and severe steatosis. So you can say that if roughly like 1/3 of the cells having fatty vacuoles is mild, 1/3 to 2/3 is moderate, and more than 2/3 of the cells having fatty vacuoles will be a severe steatosis. Interestingly, this is a paper which is published in Radiology. It was noted that when you do a visual assessment, the pathologist does a visual assessment of just the fatty vacuoles versus the assessment as the whole slide or the area of the biopsy containing the fat. It was noted that the fat as a percentage of tissue was actually lower than fat as a percentage of hepatocytes. And this is very much conceivable, because if you have a fatty vacuoles within the hepatocytes as a small area as compared to a large fatty vacuole, it can manifest as a larger percentage as compared to the one which has a smaller percentage. So if you measure the number of hepatocytes, you might get a bigger number versus comparing the area of fat within the biopsy sample, it will come as a lower number. So when you come to MRI, I'll be going straight away to MRI. I won't be talking about ultrasound or CT scan. Now, MRI for measuring of the fat is not a new concept. Clinical MRI is based on excitation and receiving signal from hydrogen atoms within the body. And the hydrogen atoms are abundant in water and fat as well as in proteins. For all practical purposes, we get signal mostly from water and fat, and to a less extent from the complex macromolecules. And then we have MRI techniques which can separate the liver signal into fat and water signals, and this is the basis of measuring fat in the body as well as fat in the liver. So fat estimation with MRI is actually a direct concept as compared to CT and ultrasound, which use an indirect concept. There are two main methods of measuring liver fat. One is measuring the fat signal fraction. Please note that signal fraction or the fat signal intensity is an imaginary number. There is no quantifiable physical attribute to it. It's a number, imaginary number. We compare that as a signal fraction. And the methods which use this fat signal fraction are MR spectroscopy and chemical shift-based techniques, or the MRI techniques. And there's another technique called proton density fat fraction. Again, it's a fat fraction. It is not an exact quantifiable number. It's a standardized objective measure for the proportion of mobile proton density to that of the liver. In all these conditions, or in all these methods, we assume that all the signal we are getting from the liver is from water and fat only. So coming to the MR spectroscopy, which is now considered as the gold standard or the imaging gold standard for non-invasive assessment of liver fat. So what happens is that we get is a spectrum of waveform, and if you see these numbers 1, 2, 3, 4, 5, 6, all these are fat peaks, and these are related to the chains, the number of unsaturated chains of attached to the triacylglycerol, and there is one water peak. So what we do is that we measure the area under this curve and attribute the area under this peak to the water, and the area under each one of 1, 2, 3, 4, 5, 6 or the different proton to the fat. And for all practical purposes, we take the area under 5, which is the methylene bond, as the representative of fat. So it is not a 100% accurate technique, because you do not know exactly where this peak ends and where this peak begins. So if you take all of it together, you're giving an estimate of the fat present in the body. So this is MR spectroscopy is highly reproducible and correlates very well with the amount of steatosis determined by histology. This is how most of the MR spectroscopy is done. Usually posterior part of the liver is selected because it does not move that much as compared to the anterior part of the liver. And about 2 centimeter voxel size, that is 2 centimeter by 2 centimeter by 2 centimeter cube is used. You can go even 3 centimeters if you want to increase the volume sample. And it is done with one breath hold technique of about 20 to 22 seconds. So the patient has to hold the breath for 20 to 22 seconds, and you are done with the spectroscopy, and you get this spectroscopy peak. And as you can see, it is labeled as small amount of choline. Then all these lipid 28, 23, 16, all these represents fat, and for all practical purposes we are taking this as the one which is representing the fat, and we measure the area of this peak to that of the sum of water and fat and measure it as a range and give it out as the fat fraction. So the MR spectroscopy gives a range of 0 to 100%, and this is one of the few techniques which gives a whole range from 0 to 100%. And MR spectroscopy has been compared to histological grade, and there is quite a good correlation, but you can expect that it can be different because we are not measuring the same place as done by biopsy. Biopsies are usually done on the right anterior aspect of the right anterior lobe, whereas the spectroscopy is mostly done in the posterior aspect of the right lobe. So it is no surprise that it does not correlate 100%, but still there is a very good correlation between the histological grade and MR spectroscopy. We can also get different numbers. The one which we mostly use is the fat-water ratio. You can also get total fatty acids by measuring all the 6 peaks which I mentioned. You can get only the unsaturated fatty acids by measuring 4 of these, polyunsaturated fatty acids by measuring 2 of them, and also you can give the chain length index. We do not know the exact use of these at the present moment, but these are all under research, and maybe in the future 5 to 6 years, or maybe in 5 to 10 years, we might find use for each one of these peaks if you have a specific interventions attacking those particular indices. I want to go on to the next technique, which is the MRI technique, in which we use the chemical shift based. So for this, I need you to imagine a little bit about 2 kinds of protons. One is the water proton and the fat proton, and it is represented by water is represented by the blue, and the fat one is represented by the yellow. So these protons, depending on the magnetic field around them, they precess or they rotate under slightly different frequency, and this is the basis by which we separate water and fat signal using MRI technique. So in the real life, these protons are spinning at different speed. At some particular point of time, if you measure the signal from the liver, you'll get a particular signal intensity. And as you can see, as these 2 are running at one particular time, they are in phase. That is, both of them are in the same phase. And that's when we get the highest signal from the liver. And at one particular time, they are totally opposite. That's called the opposed phase. That's when the signals get subtracted from each other, and then you get a very low signal from that. And this is the basis in which we do the fat and the water signal separation, the in phase representing the combined signal intensities of water and fat, and in the opposed phase, it is the difference between the signal of water and the fat. And if the fat is too high, you might get a negative value, and if the fat is too less, there might not be much change in this. So this is a study which I did in Singapore when I was there as a faculty about 6 years back. We took these museum specimens. These are specimens in formalin jars. So this is a slice of normal liver, and this is a slice of fatty liver. There's no doubt about it. Everybody can notice that this is a fatty liver. And we did this in-phase MRI sequence. You can see that there's hardly any difference except for the shading. Now this shading you see over here is actually because there's a pipe, those glass slabs which made them to keep it within the jar. And if you use the opposed phase, you can see that there's hardly any change in the signal intensity of a normal liver, but in the fatty liver the signal drops. So this is not something which only happens in live patients. It happens in any kind of fat anywhere in the body. As long as you keep it in room temperature, you can get this fat and water signal separation. So this is exactly what we use in real life. Here's a patient with fatty liver. This is the in phase. You can see a very bright liver because the signal is coming from both water and fat. And this is the one with the opposed phase where the water and the fat signal gets subtracted and you get a loss in signal. And from this we can quantify the amount of fat. How do we do it? So we take the in phase and the out phase. We can use a software to measure the ratio of them, and you can produce a grayscale map. And if you draw an ROI on that, it will give you the fat percentage. In this particular case, it's about 34. And if you want to become a little bit more fancy, you can make it into a color map. So making a grayscale map into a color map is no big deal. It can be done on a click of a button on a software. But this may probably be more pleasing for people to understand the degree or the severity of fatty change. We can also have other sequences. These are all called fancy names of the signals because each vendor tries to be different from the other vendor by naming the sequences differently. So all these this is a GE sequence called the flex sequence. It gives you in phase, opposed phase, water only image, fat only image. And this is the one which is important for us. You can put a region of interest on this and you can measure the amount of fat present in the liver. Again, when I mention amount of fat, I'm referring to fat signal fraction. It is not the exact amount by weight. And this is a DIXON sequence. It's called the KPI sequence. This is present in the Siemens scanner. It also gives you the same kind of thing, water plus fat or the in phase, water minus fat or the opposed phase, fat only and water only images. Now some of you might be wondering how radiologists differentiate between water and fat or the in phase and the opposed phase. The other tissue which has fat in it is the bone marrow. If you look at the bone marrow, which is in the spine, you can see that the bone marrow loses signal in the opposed phase, whereas it retains signal in the in phase. So if you want to identify which is the in phase and which is the out phase, look at the spine. The spine looks dark, it is opposed phase. The spine looks bright or grayish, it is the in phase. Can also do so as I mentioned earlier, these previous techniques. Let me go back. Yeah. So this in phase and out phase and the estimation of the fat from these ones are all limited because there might be other factors which may be working, which is like the signal intensities due to or the presence of inflammation, the presence of iron in them. So we do a lot of corrections to these, and we come up with a new thing called proton density fat fraction. This is essentially we're doing the same chemical shift method or the complex water and fat separation method, but we apply all correction factors which might reduce or confabulate the confounding factor for this fat fraction. And we get the same numbers, like we get the grayscale map or the color scale map, and this is considered the PDFF or the proton density fat fraction is considered to be the most accurate MRI based chemical shift based technique. And we can get the whole liver in one breath hold, which is about 18 to 22 seconds. And you can see that we can get the distribution of fat within the whole liver. And this all, like I've shown you, is about 20 slides here. of going through all parts of the liver. Actually, this patient had 32 slices, but for the sake of representation, I've taken only 20 slices to show the whole length of the whole extent of the liver. So you can see that the whole liver we can be assessed with this technique by just one breath hold, and this sequence is called as the ideal sequence on a G sequence, and the similar sequence is probably be present even in Siemens scanner. And this PDFF correlates with the histology determined steatosis. Don't be surprised by the spread of this dots over here, because it is expected, because we are not doing the quantification at the same place. We are doing at different places, because as the fatty change in the liver is not totally uniform, it can be heterogeneous. There's also been studies which have shown that the MRI quantification like this PDFF is the closest to the lipid content. That is, if you take the liver tissue, then lyse it and estimate the amount of fat within this liver tissue, then MRI comes the closest, about 0.97. CT comes next to about 0.87. Histological grading comes about 0.52. Remember, the histological grading is a different style of doing it. We are not comparing apples to oranges. We are comparing actually apples to oranges, but not apple to apple. So no wonder this is different, but this is a different way of doing it. And then automated software actually estimates the amount of fatty vacuoles within the liver biopsy sample, and that comes very closest to it. So this is not surprising, because we are doing it in a different ways and trying to correlate two different techniques. So the association or the correlation may not be accurate as good. But the good news for both MRI is that it is the most accurate one, which correlates with the chemical lipid analysis. Then another one from the research, literature, which shows that the grade 1 corresponds to about 6.4% fat estimated by MRI. Grade 2, which is 33 to 66% of hepatocytes having fat, corresponds to about 17.4% fat signal fraction. And the grade 3 is about 22.1%. Now notice that this is a very small change. 17.4 to 22 is only about 4 to 5% change in the fat signal fraction, but there's a change in the grade of histology grade. So it shows that these two techniques are talking two different things, but still there is a correlation in them. And here's another from the same study showing the distribution of the PDFF score versus the steatosis score. Now you can see that this is where the grade 1 ends and grade 2 begins, and this is grade 3. And you can see there's no close knit, or the dots don't come in one single line or very close to each other, but they are spread all around because of the variability of the assessment of this technique, and the signal fraction also varies. And you can see that the cutoff for the grade 1 is 6.14%, 17.4 for grade 2, and grade 3 is only 22. And a very narrow gap between grade 2 and 3 as compared to grade 1 and grade 2. They also studied whether the steatosis was associated with the time interval of MRI versus liver biopsy. Actually, there was not much of a change, because you can see that the correlation was ranging from 0.87 to 0.91 only. So it did not differ. It did not matter when the biopsy was done, as long as there was no significant change in the fat in the person. There was not much of a big difference between the interval of time as well as the biopsy being done. At the same time, in this study, they also found no influence of sex, age, body mass index, inflammation, or the presence of hepatocellular ballooning, and the fibrosis stage or the R2 star in this patient. And the MRS and the MRI correlates very well. The correlation is excellent, in fact, about 0.93. And this is another study showing the correlation between MRI and MR spectroscopy. This is the estimation of fat fraction, and this is MR spectroscopy showing the correlation is quite accurate. And notice that this is a very small peak in a normal patient having less than 1% fat. MRI can also be used for monitoring response to the treatment. And here's a patient before treatment had 53% fat fraction and improved to 33% after treatment. The next topic I'm going to talk about is differentiating NASH from simple steatosis. We're going quickly through this. This is an ultrasound showing 3 different patients having fatty change. And you would wonder, this patient has more fat, and probably looking at the coarse echo texture, we might be wondering this patient might be having fibrosis. And if you look at the fat fraction, it is true. This has 8%, and the last one has 34%. Now, which patient do you think has NASH or the steatohepatitis, and which one is normal? It is very difficult to say from these images which one has NASH and which one does not have NASH, and you would probably go for this one because it looks coarse. But actually the one on the top, with the one who has only fat signal fraction of 8%, actually has steatohepatitis, whereas the other two are normal because they are just simple fatty change, whereas the one with the low fat actually has more fibrosis in that and steatohepatitis, and all these are biopsy confirmed steatohepatitis, and these are just simple steatosis. And I showed this one yesterday, that we can differentiate simple steatosis from NASH using MRI elastography with an accuracy of more than 90%. And it has been shown that steatosis is non-linearly related to the fibrosis progression. In fact, it is inverse. That is, as the degree of steatosis decreases, the grade of fibrosis increases, or vice versa. As the fibrosis increases, the degree of steatosis decreases, and which we have found very true. This is a patient, 29-year-old. You would suspect that this patient is so young, cannot be having cirrhosis, but in fact turned out to be having cirrhosis, has NASH grade 1 and stage 4 fibrosis, and look at the amount of fat he's got is about 20% fat fraction in this. And this patient actually had grade 1 inflammation and stage 4 fibrosis in this. And papers have already shown that advanced fibrosis, that is stage 3 fibrosis and above, can be differentiated from lesser stages with a higher accuracy using, again, MRI elastography. And this is a comparison to show with the other scores, and obviously MRI scored much better than these other techniques. And I'm showing you a couple of examples, last ones, to show where the clinical use of fat quantification makes a difference. This is a patient this is not a patient, sorry, this is a liver transplant donor who has a body mass index of 29 and is 38-year-old male. And when he came in, and the initial assessment of ultrasound was done, and ultrasound showed a fatty liver. So the patient came for he was advised to undergo exercises and lose weight, and he came after 2 months, and you can actually see there's not much fat in this patient. There's reduction of signal, but not a very great degree. And we did MRI elastography. The liver stiffness is normal, so saying that there's low risk of having fibrosis. And if we did the biopsy, actually showed moderate steatosis. Now, this kind of disparity between MRI and liver samples is very well known. We do see that because the area where the sampling was done may be showing steatosis, but the ones in general all over the liver may not be having any difference. And this patient actually did become a donor because he did show a decrease in BMI as well as further decrease in weight, and then on follow-up his ultrasound also improved. So this was I was just trying to highlight this is where we would like to use MRI index to quantify, to in fact show before and after intervention that there is reduction in fat. Here's another example, 59-year-old female patient who actually underwent liver transplant for NASH-associated cirrhosis, and that's her explant liver, and she got a new liver. It's a cadaveric liver. And this post-transplant, the clinicians were worried whether the NASH is recurring in this patient after 6 months. And we did the PDFF, that is fat quantification. You can see the liver is dark. That is meaning to say there is no fat in it. And the subcutaneous fat, you can see it is so bright. And then we also did MRE, and showing MRE, the liver was soft. Note that the spleen is very stiff. Now that spleen is very stiff because the changes of portal hypertension has not resolved yet. And it is about 6 months since transplant, so that's why the spleen is still stiff. I want to caution one thing about is that fatty liver is not always homogeneous, it is heterogeneous, and you can have all kinds of variants. Now here's an example which we are commonly used to see, that is a diffuse fatty change. But the fatty change can have segmental variation. You can see that the posterior part of the liver is darker than the anterior part. So this may be a difference of about 10% fat in these two segments, the anterior and the posterior. It can also be multifocal. You can get patchy areas of fatty change in the liver. So this is of importance to know when you're doing a biopsy, because you suspect the patient to have fatty change, and if you biopsy over here you might get less fat, but if you biopsy over here you might be getting a high amount of fat. It can also be seen on ultrasound, the multifocality. It can be geographical. It does not obey any segmental rule, but it can be just geographical. You can see that this part of the liver is very fatty as compared to the other part, the more lateral aspect. It can be seen on ultrasound too. It can also be a variable geographic change. You can see this is an in phase and an opposed phase showing a very irregular fatty change occurring in the right lobe of the liver. And it can have spared areas of liver, that is, normal areas may be present in between the fatty change. So all this make a role where you do the biopsy so that you correlate when the results come up so that it is not surprising. And it can be sometimes very bizarre. The fatty change can be totally bizarre, and you can see that it is very patchy, it does not follow any particular pattern, and this can also be seen in this. So with that, I'll summarize that MRI is accurate for quantification of liver fat. MR spectroscopy is the imaging gold standard, and use of fat quantification, at least in our practice, is most useful for evaluation of liver donors, whether they qualify to be donors or not, and at the same time for assessing response to the treatment. And MR elastography, we use at the Mayo Clinic, is useful for differentiating simple steatosis from steatohepatitis. Thank you.